Shrikant, should I on the recording? It's live.
Yeah, we are on live YouTube. You can definitely start record download.
Shrikant, please make me host to record.
I think you can do the recording also without go as a co-host also, I think.
No, no.
So don't worry,
Host has
we already on YouTube live, so no need for that.
okay, host.
Fine.
Thank you. One minute.
It's 7 now.
Yeah. Shrikant, unveil this. Good evening, doctors. You all will agree that the using a higher generation of antibiotic to treat is nowadays is increasing. And however, these antibiotics can cause diarrhea. And there are numerous myths regarding the antibiotic associated diarrhea. And everyone should aware of it. So it is our pleasure to have today Dr. N. Arun will be speaking in today's GI Knowledge Meet on the busting the myths about antibiotic associated diarrhea. And Dr. N. Arun Kumar is a consultant gastroenterologist, hepatologist, and interventional endoscopist from Apollo Main Hospital, Chennai. And I hope today's GI knowledge meal will be useful in your day-to-day practice. And during the webinar, you can post your questions in the chat box. Now, I request Dr. N. Arun Kumar to start today's GI knowledge meet. And over to you, sir.
Thank you. Thank you. Just a minute. I'll be sharing my screen, please.
Yeah.
You can able to see my screen, sir?
Yes, sir. You can go ahead.
Okay. Thank you, Team Zydus, to give me a wonderful opportunity to talk in this wonderful evening regarding antibiotic-associated diarrhea. Good evening, respected professors, senior consultants, and my dear friends. It's really a great pleasure for me to be in this forum to discuss about this, one of the most common and important area in which most of the practitioners in day-to-day life, even as a gastroenterologist, even as a physicians or surgeons, or managing a patient, even for other consultants, when they are going to manage a patient, so they might be forgotten about the complications, whatever they are going to face. See, any post-antibiotic associated mild GA symptoms, they not be much worried about that. But sometimes what is going to happen, that may predispose to dangerous fulminant infections, what is called as Clostridioids associated difficile infection can be predisposing, and which can lead to pseudomembranous colitis and other complications, septicemia and septic shock conversion. Why I would like to point out this picture, in Indian scenario, if you're going to manage a patient with antibiotic, you need to analyze the factors properly. To whom you're going to use antibiotic, what is the rationale for antibiotic, what is the age criteria, in which sex you're going to use antibiotic, and all this, what is the clinical presentation, what is the mode of event, and depending upon the host factors and what is the organisms you're going to get target, all those things you need to analyze when you're going to use the antibiotic. And once you're going to use antibiotic, you need to assess various complications, what are the things it can predispose if you're going to use for this patient. But always you should not forget the diarrheal event. It should not be taken as a simple consideration when you're going to look for antibiotic. As I discussed, there are major complications are there to report into, and my area of interest right now with you all to disclose on this area regarding the basics of antibiotic associated diarrhea and what do you mean by the term Clostridioides difficile, now initially being called as Clostridium difficile, now the term renamed as Clostridioides difficile, and microbiological factors, risk factors and features in management. How are you going to diagnose this event? That's the most important area for me to take on the discussion with you all right now for the next 40 to 45 minutes. So regarding this antibiotic associated diarrhea, it's very common scenario nowadays. Almost from every 2% to 25% of the population who are going to use antibiotic, they are going to experience this. And various antibiotics are being reported for that. Among them, the huge list of the basic first thing right from MBBS knowledge, we will not forget about your ampicillin and amoxicillin, and fluoroquinolones will be slightly uncommon in this. But what is the basic pathophysiology when you're going to think any gut dysbiosis, because now the gut microbiota is being considered as a separate system to analyze. There are so many events for your gut microbiota to get disturbed. The gut dysbiosis is going to get established and gut symbiosis is going to get lost, and how the pathogenesis is going to get established only by mainly by your intestinal flora. The normal intestinal flora, if it is going to get altered, for example, your bacteroids, your firmicutes, all those ratio, if it is going to come down, and if your intestinal motility, if it is going to get augmented by your erythromycin and any allergic events, and there are so many other pathophysiological organisms, you need to remember that. For example, your Clostridium perfringens can predispose to various toxins, and because of that, you can go for a dangerous diarrhea. And Staphylococcus aureus, there are various toxigenic organisms can always predispose to this kind of antibiotic-associated colitis, not only in favor of Clostridioides difficile. So you should not forget all these basic points. Right from the initial presentation, any diarrheal event can go for dehydration, initial presentation, but we should not forget how the events, it could last from mild, moderate, and severe. So mild and self-limited, even most of the time the patient doesn't have any major complications, but some patient, no fever, no pseudomembrane. And what is the initial line of treatment? We need to discontinue the inciting antibiotic. And always you should be very cautious whenever you're going to prescribe antiperistaltic agents, because anti-motility, antiperistaltic agents, you need to be very cautious. That too, when you're going to use in pediatric population, there are so many data and papers have been reported for that. And always you should not forget antiperistaltic agents. You need to be very, very cautious to whom you're going to subject when you're going to manage a patient with evidence of acute onset of diarrhea. And probiotics, there are not much of beneficial effects in the management of fulminant colitis, but still, along with the other line of molecules, you can consider streptomycin, Saccharomyces boulardii, and lactobacillus to some extent as a prophylactic regimen when you're going to manage a patient with antibiotic-associated diarrhea. And what are the various differentiating factors that we should not forget? Because the Clostridioides difficile is one entity which should not get confused with other causes, other infectious trigger for your antibiotic associated colitis. So if you're going to look into this, usually if it is because of Clostridioides difficile, the diarrheal event is going to be a florid one. There will be evidence of colitis, there may be evidence of cramps, there may be evidence of high fever, leukocytosis, your fecal leukocytes will be going high, and CT scan you can able to identify evidence of pseudomembrane, which is nothing but yellowish plaque-like lesion which is going to deposit in your colon, and followed by the patients may develop multiple complications. For example, persistent diarrhea, chronic diarrhea like events, you may predispose to reduction of your albumin and generalized anasarca, followed by, and your colon is going to take on appearance what is called as toxic megacolon, and you may develop multiple multiple complications because of this clostridioides difficile. If it is not going to recognize in prompt time, and if you're not going to manage in proper time, there are high possibility for you to land up with this kind of infections. And always you should remember how to differentiate a clostridioides difficile from other causes. It's mainly whenever you're going to give antiperistaltic, it's absolutely contraindicated for clostridioides difficile, and for oral metronidazole or vancomycin, there might be evidence of prompt response. And if you're going to withdraw the antibiotic, the condition may improve or may not improve, or sometimes it may even worsen. But even then, the inciting trigger should be eliminated when you're going to manage a patient with AAD. But in other causes, it will be a mild to moderate severity because of other infectious trigger and other antibiotic focus when you're going to use. And for example, your Clinda and cephalosporin, when you're going to use that, you may be landing up in mild to moderate, which is predisposing to your worst diarrhea, what is called a nuisance diarrhea. But there may not be evidence of colitis, but findings in CT and the imaging doesn't going to yield you much. And apart from that, your withdrawal of antibiotic inciting agent, if your triggering factor, if you're going to eliminate, the pathology of this cause is going to get resolved, and antiperistaltic agents sometimes may be useful, but oral metronidazole or vancomycin, not much of indications. The new terminology for Clostridium difficile being taken over as Clostridioides difficile, that I'll be coming into the history as we proceeding into the discussion. And as we are looking into that, it's an anaerobic and gram-positive and spore-forming and toxigenic. The toxic strains A and B, which will be predisposing to multiple events when you're going to look into the pathophysiological trigger of this antibiotic-associated diarrhea. It is primary cause of nosocomial infectious diarrhea, which is going to be in developing nations, which is very common. And if you're going to look into the history, the main thing right from 1890s, the pseudomembranous colitis being first described and followed by you can able to isolate in the stool. And by 2016, the new terminology has been taken over. Now by post 2000 scenario onwards, the case reports is going high, the case fatality is going high. That's what we need to be very cautious when you're going to manage a hospital acquired nosocomial event, Clostridium difficile infection. So what are the various epidemiological changes that in pre-2000 and post-2000 era, if you're going to look into the data, the treatment failures, if you're going to see the virulent strains is going almost around 50 to 80%, the complication rate is almost going high, the mortality is slightly high in the post-2000 era, and treatment failure is slightly high, and the even after using vancomycin, the treatment failure will be reasonably okay, but even in post-2000 era, you're going to establish treatment failure and you're going to get high recurrence rate with evidence of Clostridium difficile. What are the various toxins? What is the commonest strain which is going to involve in Clostridium difficile is nothing but your NAP1 by B1 by 027. What is that? It's a North American pulse field gel eltrophorus strain which is going to get involved, which is going to get restriction endonucleases pattern and all PCR ribotype designation 027. See, what does this NAP1, if you're going to see, it is highly virulent strain, which is going to be around 16 to 23 folds higher if you're going to use a toxin A and toxin B. And it can also predispose to binary toxin for a Clostridium difficile infection. But once this kind of events is going to happen, it is highly resistant to fluoroquinolones and increased incidence of severity, your mortality, and your relapse rate is going to be high. So if you're going to look into the basics of your Clostridium difficile, the intestinal normal carrier rate will be around 0 to 3%. But if you're going to inpatient, if you're going to be hospitalized, the percentage will be around 10 to 21%. The highly resistant spores of Clostridium difficile is going to persist for many months, and asymptomatic carriers will be a reservoir. But always you should not forget the infected dose of this Clostridium difficile is very, very low, which is less than 2 spores can be able to infect your GI tract as the day progresses. But once, how are you going to categorize this? It could be categorized as hospital acquired or community acquired. Once you're going to get hospitalized or immediately after discharge, if you're going to establish your GI symptoms in the background of colitis, then there is evidence of Clostridium difficile hospital acquired event. And community acquired, it can in whom the patient doesn't have a major risk factor, any recent antibiotic source of exposure, if it is there, then you can consider as a community acquired CDI. But What are the predisposing antibiotics? The frequent one we should not forget all is ampy and amox and cephalosporins. That's a frequently used antibiotic right from your dermatological practice, right from ENT consultants, right from GI, right from obstetric, everywhere the frequently used scenario will be your ampy and amox. So we should not forget, not only for drug-induced liver injury, also for your antibiotic-associated colitis is one of the commonest trigger which is going to be reported, and that's why I'm checking this area to present right now with the all. And cephalosporins, clindamycin, fluoroquinolones, that's also been frequently, and these are all the rarest of rare causes. That's not much of interest right now for the discussion. And apart from that, the basic pathophysiology is once you're going to start the patient on antibiotic therapy, it is going to alter your colonic microflora. If the colonic microflora, if it is going to get altered, what is going to happen? There will be high evidence of exposure and colonization of your Clostridium difficile, and that will predispose to various toxin production. And if it is going to have a protective response, it becomes a asymptomatic source. And once a patient doesn't going to establish any protective response or any immune response, if it is not going to get formed, the patient is going to land up with fulminant event. So this is the mechanism of how the colonization resistance is going to get established. If you're going to look into the pathophysiology of your antibiotic, Clostridium difficile. So the main thing, what are the things? If these are all the various normal gut commands being located, your E. coli, lactobacillus, what they're going to do by addition, by micronutrient limitation, by carbon source limitation, in which based upon that your Clostridiums, even if the pathogenic source is going to get prevented, and followed by once these things, if it is not going to get involved in that, there might be evidence of your virulence factors to get released into the lumen, and followed by you're going to land up in worsening of events, followed by your pseudomembrane formation, other complications going to take on. And basically, if you're going to look into these toxins, this complex area, the complex area to understand, first you should remember the toxin A and toxin B is one of the most common. The TCDA and TCDB source, what we are going to see, and toxin A, B is always more potent than toxin A. But if you're going to see that one thing, what is called as TCDR, it comprises your TCDC and D. And what is going to happen? It is going to involve your transcription process. Here, the RNA polymerase is going to get involved in that, followed by the transcription process is going to get activated, and the various toxins is going to release. And then in this process, if the TCDC, if it is going to get activated, there might be evidence of toxin transcription will come down. But once the TCDC, if it is going to be activating, and there will be lysis of your cytoplasmic membrane, which will be predisposing to your various toxin release, and fulminant event is there to supervene at that point of time. So this is the basic physiology. That's not much in consideration. We should be remembered about the basic thing. Once the patient, the glycosylation, if it is going to get take on the various domains, if it is going to get remembered. So you always, if you're going to look into this is nothing but the hydrophobic domain of your component, what you're going to get. Once it is going to get involved, the RNA polymerase, all those things, if it is going to get activated, and once the endocytosis, if it is going to take on, and followed by the pathogen is going to get entering into the tract, and there might be evidence for your Rho transcription process to get affected. The inhibition of your glutamate process is going to get happen, followed by your worsening of events is there to take on. How the immune response is going to be involved in your Clostridium difficile. Always, any mucosal pathology, we should not forget our IgG as well as your IgA. So serum IgG and IgA antibodies are against Clostridium difficile. Your mucosal IgA antitoxin antibodies is going to be high, and high concentration of antitoxin, which is going to definitely protect you from your Clostridium difficile. But once the concentration, if it is going to go down, if you're going to look into this, there is evidence of recurrent Clostridium, the single episode, asymptomatic coverage. As it progresses, the level is going to come down. So once if it is going to come down, the worsening of treatment, the worsening of response is going to get happen. This is a basic outline how the event is progressing. If you're going to look by any healthcare persons or any iatrogenic source, if you're going to expose yourself through the healthcare, you're going to see your poor hygienic practices by your environmental exposure. And what is going to happen? You're going to inoculate your Clostridium difficile into your GI tract. And what is going to happen? It is going to release the various toxins. Once the toxins get released, it's going to inactivate your raw GTPases in your colon cells, and there will be further inflammation, which will predispose to multiple complications, and followed by always any GA event, any event. We should not forget one simple thing, what we are supposed to remember. It is going to progress to sepsis, severe sepsis, septicemia, and shock. That is all the nature of event. Once the shock is going to get take on, there might be evidence of organ dysfunction. It could be single or multi-organ. So that's all we need to remember. Hypertension, renal injury, all those things is going to get take on once the patient is going to land up with worsening of events by your cytoskeleton disruption. And this iatrogenic process by your antibiotic, any GA surgery, any chemotherapeutic, always you need to be very, very cautious when you're going to use PPI for long duration of time. That's why you need to be very cautious. Even as a gastroenterologist, we need to think about that. How are you going to use PPI? To whom you're supposed to subject the PPI? But PPI is still having a reasonable exposure, which will predispose to your increased acid suppression, followed by there might be evidence of your gut microbiota to get disrupted, followed by there might be clues for your glucosidase deficit to get activated, and various comorbid conditions like your cirrhosis, your IBD, all of the things can predispose. And your as the age progresses, if your female population, there might be evidence of worsening of events to get happen. But once this event sets in, either it can go for toxic megacolon or perforation or bloody diarrhea, or various abdominal cramps can be reported. But we should not forget this basic outline. It could be because of your natural source of health-related exposure, or it could be because of iatrogenic, which will predispose to toxin release and various complications. So spectrum of the clinical spectrum is simple to remember. It can be asymptomatic, as most of the disease process can happen, and sometimes it can go for moderate event, and sometimes a life-threatening complications like toxic megacolon or pseudomembranous colitis can develop. As what you're going to look into this carrier state, 10 to 20% of the patients, they may be asymptomatic due to adaptive protective immunity. If it is going to get an hospitalized patient who is going to receive antibiotics, so there might be evidence of your adaptive immunity is going to be activated. At that point of time, the carrier state is going to be there. And what is this diarrhea? If it is going to be there, there might be a minimal diarrhea or massive output or leukocytosis, your cramping pain. As we have discussed, your GA bleed can be there, along with it's usually not much of invasion, and extra-intestinal manifestation will not be reporting much in case of Clostridium difficile, like your septic arthritis or bacteremia or tissue abscess. But evidence of large joint arthropathy, audioarticular involvement can be there, but these are all the rarest and rare focus. And you can also consider a reactive arthritis pathology when you're going to look into all this scenario, but that's out of discussion right now for all. So what if the patient is going to land up with severe disease, colonic ileus, a toxic megacolon? At that point of time, the diarrhea may or may not be there. So it doesn't mean that why the patient is having antibiotic associated diarrhea in severe form has to land up only with evidence of severe diarrhea. No. Once the patient is going to take on appearance in your imaging, if you're going to look into various findings, if you're going to see a thumb printing or accordion sign, that might be a significant pointer for you to think that the patient is going for worsening of even a clinical presentation of ileus is going to decide all the clinical events, how the patient is going to get progress. So these are all the various presentation. As we all remember the complications, I think I already discussed. It can lead finally to a perforation and other complications, septicemia, septic shock can predispose. And how are you going to diagnose? That's one of the interesting area. And how to manage. That's one of the most interesting area for us to discuss in a short span of time. Whom do you subject for investigation for this antibiotic associated diarrhea in India? Because it is one of the costliest investigations. It can't be afforded. You can't do in all the patients. That one thing, it should be addressed. And next to that, to whom? If you're going to have a hospital acquired source, a nosocomial source, or any immunocompromised focus in the background of new onset of diarrhea, if the patient is going to have 3 or more unformed stools in 24 hours, especially if the patient is going to have evidence of antibiotic exposure within previous 2 or 3 months. So we can subject them, but no need to do a follow-up testing to confirm whether it is responding or not. And if the patient is going to have a solid stools or formed stools, no need to test for that kind of patient. So sample collection is very important. Mainly, if the patient is having, we need to collect a freshly passed stools in clean, watertight container, rectal swab for ileus patients, and Media is not of much important, and apart from that, the temperature maintaining is very important, because if delay is there, you can refrigerate this sample of clostridials, the swab what you're going to get collected. And what are the various modalities in which you can diagnose this clostridial difficile event? By the most important, you can do a combined assay, but your enzyme immunoassay and the CNNA, that's nothing but cell culture, cytotoxicity, and neutralization assay you can do, and your organisms you can able to identify by the various component like glutamate dehydrogenase, your PCR for nucleic acid amplification you can do, and your stool culture. But it's how far it is going to available, how it's reachable for most of the patients, still a question in India. But it's enzyme immunoassay and stool culture, definitely we can try. If you're going to suspect, if you're going to see a pseudomembrane, if you're going to have a clinical presentation, rapid worsening of events in the background of IBD, if you're going to treat a patient followed by the patient scenario is rapidly worsening, if the patient is going to land up a worsening of diarrhea, there might be evidence for you to think in terms of clostridioids deficit, which is that to supervene when you're going to manage. This is the basic sensitivity pattern when you're going to see your various toxigenic cultures, your CCNA, your GDH, your nucleic acid amplification, and your enzyme. So as far as I'm concerned, the most of the things will be in same sensitivity and specificity, but how far it is going to yield a significant result, then you're going to see this clinical presentation, and followed by you need to see a combined assay of your GDH as well as your toxin assay by enzyme immunoassay samples. Once your GDH, if it is going to get positive and toxin is positive, it's confirmatory. If any one of them is negative, you can go for a nucleic acid amplification. And if both are negative, it's almost conclusive that the patient doesn't have evidence of a CDI. But sigmoidoscopy and colonoscopy is not warranted for all the patients, but you can definitely do when you're suspecting a clinical presentation, and we can able to identify multiple raised plaques and intervening gaps are there, followed by the size of the lesion will be around 2 to 5 millimeters, and some case reports are even going up to 7 to 10 millimeters of gap of multiple lesions may be reported. A membranous component you can able to identify in this, which is one of the worst triggering. If you're going to see this kind of presentation, you need to manage the patient in an effective way to prevent this complication. Along with, you need to serially monitor this kind of presentation. It doesn't mean that if you're going to land up a patient who have been treated with antibiotics, doesn't mean that patient is mainly because of clostridial deficit. And always you should remember the closest differential diagnosis in the field of practice. We should not forget sometimes your ischemic focus. You always, this kind of pseudomembrane is mainly by your ischemic involvement, any ischemia which is going to get triggered by your disruption process, which is going to get augmented. That is why we need to should not forget any ischemic events or surgical process or any infectious trigger like your Shigella or necrotizing enterocolitis or any malignant lesions in your colon, or the one of the commonest septicemic focus infection like Staph aureus, or other severe insults, the extra GI insult like your severe burn, AKA. These are all the events which will predispose to gut ischemia. The gut ischemia, there is high possibility for you to land up with evidence of a pseudomembranous colitis. And you should, this is a simple thing, we can able to identify the toxic megacolon, the dilated colon. If it is going to be the diameter, you can see very well if it is going to be more than 7 mm, the multiple air fluid levels, you can able to identify that possibility of toxic megacolon is there. The thumb printing sign, one which the ostral folds is going to impinge the colonic folds, it's going to get thickening wall, that shows evidence of multiple thumb printing like appearance in pseudomembranous colitis, you can able to identify. And CT findings, you can able to see accordion sign. The bowel wall is going to get thickened, and accordion sign. See, you can able to identify very well if you are going to look into this. So what does this accordion? It's the instrument what we are going to use to play when you're open, just to open and close your hand like that. When you're going to play with this instrument, you can able to see how the string of appearance is going to be there when you're going to use this accordion sign to diagnose. And typically the whole colon is involved, but right side colon and transverse colon affected in isolated cases. Up to 5% of data are still being there. Rectal involvement being the majority of patients, more than 90% of the population is mainly by involvement of your rectum. So sigmoidoscopy itself can yield a reasonable diagnosis, but always if the patient is feasible, if the hemodynamic status is not worsened, it's better to go for a complete full-length colonoscopy for this kind of patients to diagnose this worsened event. and summit sign or volcano sign, in which you can able to see a focal ulceration with the evidence of pseudo-exudative pseudomembranes with inflammatory cells. What you're going to see is nothing but your summit or volcano sign. What you're going to diagnose, always how are you going to manage? It's one of the very important and interesting area, because here the challenge comes how to diagnose and how to manage. First, eliminate the triggers. You need to eliminate, stop the precipitating focus, and minimal use of concomitant antibiotic. But we need to assess other clinical parameters of the patient to whom we are going to stop. What are the various coexisting comorbidities is there for the patient when you're going to stop the antibiotic? If the scenario is going to get worse, and then you need to continue the antibiotic at a reasonable rate. That we should not forget. But once the antibiotic gets stopped, the diarrhea usually resolves in 15 to 20% over a period of around 2 to 6 weeks without any major management. So anti-motility, always you need to be very cautious, because the toxin clearance will go down, the ileus may worsen, your megacolon may worsen. And this is a basic regimen. All the patient, we should not forget your leukocytosis, if it is going to be very high, your creatinine is going to be high, if your albumin count, if it is going to be low, if it is going to be less than 3, that shows evidence of severe clostridoids is going to take on. At that point of time, we need to give oral vancomycin for 10 days. A QID regimen or fidaxomicin can be considered a BD regimen of 200 milligrams for a period of around 10 days. But metronidazole also, most of the condition we can be used, but metronidazole, one problem, the patient may exhibit a metallic taste, some patients may exhibit a neuropathic changes, some patients, if the patient is having evidence of alcohol, can exhibit a disulfiram-like reaction. These things can happen when you're going to use metronidazole. But always, when you're going to think about this kind of management in Indian scenario, combine oral vancomycin along with oral metronidazole to yield reasonable report in the background of your probiotic, whether it is there or not. Apart from that, the vancomycin is a basic molecule like your glycopeptide. It can be used safely in your pregnant as well as in children. And usually the high concentration will be achieved in your colonic lumen. The systemic side effects will be less. So the improvement, the clinical response, you can able to identify within a span of around 72 hours. And usually the complete resolution will occur in most patients by the end of 10 days, of course, when you're going to use for a mild to moderate event. As I discussed, the various dosage regimens was initially by 125 and 500 milligrams doses are there, but 500 milligrams and 125 doesn't going to have a major difference. Even you can go by 125 very safely, and 500 milligrams also not going to yield a major therapeutic response difference when you're going to manage. So 125 QID for 10 to 14 days, BD for a week, and OD for a week, and then every 2 or 3 days for almost a span of around 2 to 8 weeks, maximum 2 months of duration. You can consider vancomycin in the background of mild to moderate colitis when you're going to use. And this is the response when you're going to use a moderate 125 or 500, that doesn't yield the day of treatment response, all those things, and the fecal vancomycin concentration, this is going to attain, doesn't going to have a major difference. So 125 itself is having a reasonable beneficial role when you're going to use. What about this fidaxomicin? It's nothing but a macrocyclic antibiotic, which is going to give, inhibit your RNA polymerase. And the one thing, if you're going to use the fidaxomicin, the low recurrence rate will be there in compared to vancomycin in patient who are going to present you with evidence of first recurrence. Always, we should not forget the membranous colitis, pseudomembranous colitis can have evidence of recurrence of symptom. It could be first recurrence or second recurrence or refractory. There might be evidence of various presentation. At that point of time, you need to consider other line of management also that I'll be discussing in the upcoming slides briefly. But fidaxomicin, you can consider the dose of around 200 milligrams for patient with an initial clostridial deficit and CDA recurrence. Fidaxomicin use rather than a standard dose of vancomycin can be considered as per your IDSA and SHE guidelines, what they mentioned. And this is how you're going to look into the trough, and when you're going to use your vancomycin and fidaxomicin, and this is how it's going to show the response. And there are so many other medications are there, like your teicoplanin, nitazoxanide, your rifaximin can be tried. Most of the patients in gastroenterology nowadays with diarrhea, who's having evidence even in travelers or other dry area, when you're going to use a there is high possibility for most of the gastroenterology they are using rifaximin. So you can give for a span of around 20 days of rifaximin support. That is what is called as a chaser regimen. You can augment your clostridial difficile rates. Is going to come down from 30 to 15%. Bacitracin and various binding resins can be tried, but that doesn't yield a significant response when you're going to manage. So there is not much of consideration in the management process of your pseudomembranous fulminant colitis. The one important thing about your fulminant colitis, as you are going to identify evidence of septicemia with hypertension, with multi-organ dysfunction, and evidence of elevated serum lactate, what are you going to do? So you need to establish, you need to maintain a proper airway breathing and circulation. That's a basic. We should not forget volume resuscitation, assess a patient hemodynamics, that has to be maintained promptly. And oral vancomycin, we can consider 500 milligrams, but if the patient is having evidence of ileus, then you need to be very, very cautious. You can administer vancomycin through nasogastric tube with intermittent clamping, and always you can also consider vancomycin enema can be considered. Along with, you can add a metronidazole support of parenterally 500 milligrams can be considered when you're going to use. But fidaxomicin role in the management of fulminant colitis is not well documented, not well established as per your ACG position statement, what they mentioned in 2021 guidelines. So regarding what is this salvage therapy, if nothing is going to get work on, if your metronidazole is not functioning, if your vancomycin is not functioning, then you can consider tigecycline and immunoglobulins can be considered. But how far the response rate, the various papers not been much of beneficial quad, but you can try this immunoglobulin and tigecycline as a salvage regimen, but soon you need to titrate the dose and other guidelines to be ensured if you're going to manage a patient with CDI. Surgery, always we should not forget, once the patient is having evidence of worsening of events, no response to medical therapy, that's the indication for surgery. If your ileus, if your fever is going to get worse, and if your counts is going to be high, and all these complications, if your septicemia and septic shock is going to get progress, then you may consider the patient for total colectomy with an ileostomy and staple rectal stump. Or else you can consider a diverting loop ileostomy with colonic lavage and vancomycin. So the loop diversion process you can consider along with your vancomycin. You can instill along with your pegylated solution, what you're going to use, a high electrolyte solution. You can substitute with the patient, and you can give a colonic enema of vancomycin 500 milligrams and 500 ml for almost a period of 10 days via the ileostomy site. You can consider these are all the various paper what have been taken from manual of surgery. So you can consider once the patient is going to land up with evidence of fulminant clostridial difficile infection. And fecal microbiota transplantation is one important thing, because right now from alcoholic hepatitis, so multiple other etiological causes, but we are going to work up for fecal microbiota transplant, even for your IBD and other conditions. Rarely some trials are going on for IBS also, but fecal microbiota transplant for severe and fulminant clostridial difficile infection, what you're going to see, that terminology has been replaced now by IMT. It's nothing but intestinal microbiota transplant. So what is that? Why they have removed that terminology from post 2017 and 16 onwards? Because what they've been considering for fecal microbiota, the fecal is an entire source, and it doesn't sound good, and most of the patient will not accept with that. So in order to avoid this, you can consider alternatives that's been given in other papers. That's other terminology like intestinal microbiota transplantation being taken over in the new area of discussion from 2019 onward. So what you're going to do, you need to give a anti-CDA antibodies along with your fecal microbiota transplant, what you're going to see. And you see in concomitantly, you can administer your vancomycin and fidaxomicin. Always you need to continue. And you need to repeat this FMT along through the colonoscopy with a gentle CO2 insufflation. You should not be in very fast way, and you need to make sure once you're going to do your colonoscopy, you need to advance the scope beyond the splenic flexure, and from there only you need to instill your microbiota, fecal microbiota in that area, and you can repeat that every 3 to 5 days until the pseudomembrane, if it is going to get resolved. Once if it is resolving, there might be evidence of response. Then you can taper down the dose of vancomycin and fidaxomicin for this kind of patients. So you can consider FMT once the patient is going to land up with fulminant colitis. The other pointers is like clostridial difficile recurrence, we should not forget. Once the patient is having, if the patient is going to respond almost 80% 25% first recurrence, 35% second recurrence, and 50% after multiple recurrences can be there. 50% chances are there. And why? What do you mean by this recurrence of diarrhea? If you're going to use an enzyme immunoassay within a span of 8 weeks of treatment after initial episode of CDI, if you're going to have another recurrence of event, that shows evidence of your recurrent diarrhea of clostridium deficit. So at that point of juncture, you need to look for other differential diagnoses like IBS or a microscopic colitis or celiac or lactose. The risk factors is very high. If the patient is immunocompromised, multiple medications, your immunosuppressive regimens, your PPIs, your antibiotics, and other doses, if you're having prolonged hospitalization, nosocomial induced, and when you're going to land up with other comorbidities, that shows evidence you may be having evidence of recurrence of your clostridial deficit. Once a patient is going to have recurrence of clostridium difficile, you can consider vancomycin or fidaxomicin and once the main thing, you can add a fidaxomicin if vancomycin was used for the initial episode. So in this kind of condition, the role of fidaxomicin is slightly going higher, and rational of pulse therapy is usually well minded when you're going to use that. Either you can go for extended regimen of fidaxomicin or tapered regimen of vancomycin, and you can use the rifaximin chaser as what I have mentioned for your period of around 20 to 30 days. You can consider vancomycin for this recurrent event. The basics. Next to that, few points about your intestinal microbiota transplant before I'm going to wind up the session. And this is going to establish your gut symbiosis and prevent your gut dysbiosis. That's how you need to maintain your normal colonic flora in order to instill some amount of stool in your GI tract. So the main indication will be a recurrent CDI or refractory CDI. And always you need to screen. That's a such huge protocol. That is why in most of the centers, it is a very cumbersome procedure to do. But in research-based workup, if you want to prove that, you can always try with this negative screening. We need to screen the stool samples for all this, and we need to screen the stool sample for all this. So we need to confirm the patient doesn't have any major event when you're going to do a fecal microbiota transplant, which has been renamed as IMT now. And you can give the IMT either by colonoscopy or retention anymore, by capsule or by upper GI modalities. And you need to see the response resolution. If the patient is in a large intestine, but what we are commonly encountering, around 93% in cecum and ascending and distal colon, the resolution will be almost around 84% if you're going to use FMT. But the most important criteria, you need to choose a BMI patient of more than 18, and you need to be around more than 18 years of age and less than 60. The stool collection should be standardized, and usually greater than 50 grams of stool to be collected for each IMT preparation, and it should be mixed with 1:5 of diluent to make the initial fecal emulsion, and make sure it has to be frozen at a temperature of almost around -80. So this kind of preparations we can consider. But what they have mentioned, there might be evidence of efficacy around 95% when compared to when you're going to use a simple regimen. And in this paper, what they've been using fecal microbiota transplant. There are some mild events of safety profiles like your bloat, cramps, all those things can report when you're going to use IMT regimen. A risk of infections like your extended spectrum lactomases, like your E. coli bacteremia can happen, and some rare events in immunocompromised patients can report, but fatal pneumonia, aspiration pneumonia, because once the feces is going to get aspirate, there might be evidence of possibility, but there are certain papers that are there to quote all this finding. But now we need to be cautious to whom we are going to choose a recurrent event. That's the most important thing to get addressed when you're going to manage a patient with a recurrence of CDI. And prophylactic vancomycin is indicated who are not at all a candidate for intestinal microbiota transplant, who is going to relapse after your IMT, and who are going to have a frequent course of your antibiotic. Then you can consider the patient for oral vancomycin prophylaxis. Oral vancomycin prophylaxis, you can give 125 milligrams once daily, which is going to continue typically until 5 days after completion of your systemic antibiotic. But no significant increase your resistant enterococcus or other infection rate being reported. But usually you should not forget any high-risk groups of patients more than 65 or immunocompromised who are hospitalized for severe CDI to be used oral vancomycin prophylaxis before you're going to discharge. Apart from that, the newer events, what we've been trying but not in our center we have been using as of now. But antitoxins like besilotoxumab for antitoxin A, antitoxin B, and for actoxumab for antitoxin A can be considered, but it is going to neutralize your toxins. But actrosumab has not been much effective in reducing your CDI recurrence, but besilotumab has been proven some efficacy at the rate of around 10 milligrams per kg with fewer CDI recurrences being there. In this paper, you are going to look into that. If you're going to use for immunocompromised or severe CDI, there might be evidence of recurrence rate is slightly going down when compared to the placebo when you're going to use this antitoxins for a long duration of time. As per IDSA and SHEA update, what they mentioned, for recurrent CDI, besilotumab can be considered in patient with primary CDA episode and other recurrence factors for CDA recurrence, immunocompromised. You can definitely, there might be evidence of some beneficial role. Probiotic, as I discussed with you, lactobacillus rhamnosus GG, Saccharomyces boulardii, there might be some clues to respond. But in this paper, if you're going to look into that, when compared to placebo with your probiotic, not much of beneficial role in the background of antibiotic colitis. Before concluding, you should not forget few points about your inflammatory bowel disease that is going to worsen if the patient is going to have evidence of CDI along with your IBD. The evidence of worsening of event will be fourfold higher when compared to this. So always you should remember that you can continue vancomycin and check your albumin levels, check for other predictors, rule out the indices, check all the parameters when you're going to use, and you can use a sequential versus concomitant your antibiotic and immunosuppressive therapy. What do you mean by that? If the patient is having inactive IBD, which means IBD is well controlled, but you are going to have only evidence of CDI, then you can give a CDI antibiotic therapy with maintenance of IBD therapy, what you are going to give before you can continue. But inadequately controlled IBD patients, you need to escalate the dose and you need to take care of your anti-clostridial difficile antibiotic also. So sometimes you need to escalate the dose of your immunosuppressive regimen, and you should not always, you don't need to withdraw or stop therapy. That is one important thing you need to consider, because you need to escalate the dose to prevent the flare, to treat the flare at that point of time if the patient is going to land up with the evidence of IBD along with the evidence of Clostridial difficile infection coexisting together. Pregnancy and lactation, vancomycin has been the papers are there to report the efficacy. Fidaxomicin, not much of data are there to show the efficacy. And vaccines being tried, but still we need more papers to look for the augmentation. And in chemically inactivated toxoids for A and B toxins were being tried, but the early clinical trials vaccine was immunogenic. But phase 3, it shows more clinical response not being there, and we need more papers to document all this beneficial role. Prevention, as I told, you need to identify the source, control the infection's etiology, and avoid major use of antibiotics unless it's strongly indicated, and until it's strongly indicated, and take care of your hygiene, your environmental cleaning, and antibiotic stewardship is very important, and need to consult with your ID team when you're going to manage a patient with this kind of scenario to overcome all the complications successfully when you're going to manage a patient with IBD. When you're going to manage a patient with antibiotic-associated diarrhea or even in the background of IBD. With this, I'm happy to rest my presentation and thanking you all for patient listening. And so I'm happy to take up your questions if anything is there to take on.
Thank you, sir. Thank you for your talk. And there are some questions, sir, which has been asked in this zone, which is in chat box. Some of them are asked. Dr. Satya has asked: are some antibiotics more likely to cause diarrhea?
As I discussed with you all, the commonest antibiotic will be all amoxicillin, ampicillins, and fluoroquinolones is slightly the lower side, but the high chances of common things always your cephalosporins and ampicillin you should not forget when you're going to use.
Yes. And sir, should I take probiotics with other medications?
Always you can consider probiotic with other medications safely, but usually now the probiotic role has been well established and well documented, not only for GA conditions, even for multiple other pathologies. For example, your non-GA condition, for example, your obstetric condition, for example, your respiratory condition, all those conditions, there are role of probiotics have been well documented, and you can definitely make a trial with your probiotic lactobacillus regimen can be well maintained, but how without only lactobacillus based regimen, not supposed to be in the case of fulminant colitis if the patient is going to take on that area. Apart from that, a coexisting of vancomycin, fidaxomicin along with the metronidazole, you can definitely consider your probiotic for a duration. I mean, as I discussed with you all, 10 power 6 of main of your commensal source has to be well established if you're going to manage a patient with this kind of scenario.
What are the symptoms of an allergic reaction to an antibiotic?
This is very common. Symptoms of allergic reaction from an antibiotic, right from head to foot, anywhere, any symptoms can happen. Allergy is one big entity that cannot be discussed in one simple area. But always you should remember allergy stands for everything. The triple A, it could be because of atopy, allergy, eczema, asthma, all those things can happen. You can give respiratory events, you can get cardiac events, you can get eye irritation, you can get oral irritation, you can get erythema, you can get rashes. What to say about the symptoms? There are a huge list of symptoms is there when you're going to look into the allergic reaction, not only pertaining to the antibiotic, but you need to be cautious whether it is because of antibiotic or whether it is because of other sources. We need to look for evidence of viral focus. There are so much of rheumatological triggers could be there, or coexisting other molecules could worsen the scenario. It's such interesting area. The whole day of medicine is one not enough to discuss about this allergy in various antibiotic response.
Sir, treatments to cope with mild antibiotic associated diarrhea.
Mild antibiotic associated diarrhea, just wait, watch conservatively. Nothing else is needed. Just eliminate the source, look for the worsening of event, check the patient, assess the nutrition status, assess the weight, assess the comorbid events. And if the patient doesn't have any evidence of septic or worsening focus, if the gut looks to be fine, wait, watch, which will yield a better response for most of the patients when you're going to manage.
Symptoms of antibiotic associated diarrhea.
Symptoms, that's what I mean. It could be mild, it could be moderate, it could be severe. Mild to moderate means nothing much to worry. Severe, as I discussed, toxic megacolon, that abdomen becomes bloated. You cannot, the ileus, if you're going to put a scat, you couldn't able to identify any sound. The complete paralytic nature of your stomach, that's nothing but your paralytic ileus is going to take on. And that point of time, you need to be very, very cautious to manage. So maintain the patient nil by oral, put the patient on a nasogastric tube and manage the patient conservatively. Look for the dangerous alarming symptoms. And even when you're going to do sigmoidoscopy or colonoscopy, at that point of juncture, you need to be very cautious whether you need to subject the patient for that kind of investigation there or not. But overall, when you're going to look, if you're going to manage a patient classically, when you're going to be a good gastroenterologist in your practice, this kind of presentation can be recognized at the earlier point of time, and you can able to eliminate the inciting trigger.
Thank you, sir. All the questions you have answered. And good evening, all. On behalf of Zydus, I, Muhammad Wasim, would like to thank Dr. N. Arun for his wonderful presentation. It was indeed our privilege to listen to you, sir, and busting myths about antibiotic-associated diarrhea. Last but not the least, my thanks to entire participating clinicians without whom the event would not have been possible. It goes without saying that we will continue to rely on your affection and support now and hereafter. Thank you and have a great weekend. Good night and stay safe.
Thank you all for patient listening. Thank you very much, Team Zydus, for organizing such a wonderful event. Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you. Thank you, sir.
Thank you. Thank you.